Everyone, one more minute for people to trickle in to the Zoomverse.
Berk, welcome. Nice to see you.
Is this Jesse?
Yeah.
Hi, Jesse.
How's it
Nice
going?
to see you too, although I'm not seeing you. Let's see. Oh, there you are.
I'm
All
gonna
right.
wait
Hi
more
there.
vigorously.
Thanks for coming.
Yeah, of course.
Jesse is my neighbor.
Oh yeah?
Yeah, and a good friend.
He's my office neighbor, although I never see, no one ever sees anybody anymore, except on.
Yeah, so sad.
Well, we're heading, I think, to normal, so
Sorry, hold on, Taco. Hi, Jesse.
hello.
All right. I think we should get started since we have over 40 people here already, which is awesome. It's great to see you all. Thanks for coming. We are super excited to have Berk Ozler with us today. He's the lead economist and research manager within the Development Research Group at the World Bank. And he is going to talk to us today about his work on contraception and willingness to pay for contraceptives in Cameroon, I believe. And for those of you who don't know Berk, he is a impact evaluation expert and one of the regular contributors to the Development Impact blog, which I personally and many of my colleagues find to be perhaps the most valuable resource in impact evaluation and what's new and what's old, and in guiding us, those of us who do impact evaluation work. So we're super lucky to have him. The plan will be for Berk to talk for 35 to 40 minutes with interruptions for clarifying questions, and then we'll open it up to Q&A. Feel free to put questions in the chat, and Berk, feel free to ignore what's in the chat until you're ready. Over to you.
Great. Thanks very much for that kind introduction. I'm also happy to be here. It's actually nice, like I actually see, in addition to my neighbors and friends, I see a bunch of people that I've known from the past, the people I worked with, like Sebastian is there, Jan is there. Hello, everybody other people I know that I haven't seen. Thanks very much for coming. And I understand a lot of Jess's students are here. So I'll try to have some ideas for you for future work, and then maybe we get to talk a little bit about adaptive experiments at the end if there's interest. So let me give a little background on like why I am doing this. So all of us, kind of like get bugged by a problem, and then we just start doing research on it if we have the freedom to do so. This is one that's just kind of been bugging me for the last like 5 to 8 years, is kind of like, why are there so many unintended and unwanted pregnancies? That's the question that's been kind of bugging me. But, it was bugging me, but not enough that like I would actually say, okay, I'm going to do something like about this. And then one year we were at the Pop Council meetings in Addis Ababa or something, and I was in a session. Actually, my co-author was in a session presenting our work from Malawi, where we talk about cash transfers and sexual behavior. And there was another paper in the session about a family planning intervention and education, so going at it the other way. And then the discussant was Andy Foster. I don't know how many of you know him. He's a famous economist, does more theory development stuff. He essentially, I never seen a discussant do this before. He had essentially written like a little model that encompassed both papers. And then he was essentially speculating on which one would be more cost effective for human capital accumulation, like let's say at age 25, if I had an effective family planning intervention for adolescent females, or if I had cash transfers to go to school. And he had put some back of the envelope numbers to it, and he was speculating that family planning interventions may be more effective. So then I said, hey, Andrew, you know, this is an experimentable like question. We can actually trial this out. And he was like, oh yeah, that's exciting. Let's try to do that, etc. But then as I started thinking about it, we knew what to do on the cash transfer side. Yes, okay, cash transfers, they work. We know how to deliver them cost effectively, etc. But then I quickly realized that I didn't know the intervention to do on the family planning side for adolescent females. So that's when the search started. It's kind of like, what intervention can we do that will significantly increase uptake in a cost-effective manner that it could actually compete with, like, let's say 3-4 years of monthly cash transfers for people conditional on going to school or something like that. So that experiment is still waiting to be done. So for all the graduate students out there, here's an idea for you, like go run with it. And maybe this will give you some fodder as to what kind of things might work on that family planning end. So like I said, the motivation here is that nearly half of all pregnancies worldwide are considered either unwanted or mistimed. And they are a major contributor to persistently high maternal mortality. And we're talking about Cameroon here, where maternal mortality is very high. It's about 530 and 100,000 live births. And it's not been going down a lot recently. And that's an order of magnitude larger than places like Vietnam and Brazil. And it's 2 orders of magnitude larger than places like Netherlands, right? So it's very high. You know, if we think about, let's say, if all of us were like women of like childbearing age in this room, in this virtual room, one of us would be expected to die of maternal reasons in our lifetime if we were in Cameroon. Right, so it's that high. 1 in 35 or so is roughly the chance. So, and not only that, there's lots of kind of you know, loss of welfare for the person who has this kind of like accident, and we can debate how many of these things are actual accidents or people don't care or not, but there is some welfare loss. We can, I think, safely speculate that. And then these events are also negatively associated with human capital accumulation, both for the person themselves and then their children in the future. Right, they're negatively associated with spacing, for example, and birth weights and things like that. So all sorts of things go bad. So the reason it was bugging me was I was thinking naively as a male person who doesn't have experience with contraceptives of this kind. I was like, well, the technology exists. Why don't people use it? Right? That was my initial entry to this. Of course, it's not as simple, but it is true that we have 99.9% effective methods to avoid these events, but take-up rates remain very low. And the main factor is really side effects. A lot of people try these things and then they just don't work for them. So they switch and they switch until they find something. And sometimes what they find is not a long-acting method, which I'm going to refer to as LARC in the rest of this talk. There are misconceptions about reversibility. People worry that they can get infertile using these things. These things are not free in many countries, including the United States. Actually, they're quite expensive in the United States. There are discretion issues that people don't want to know other people are using them. There's opposition by parents, spouses, partners. And then on the supply side, there's also a jillion things like in developing countries, such as in the hospitals we work in, stockouts regularly happen. Like there's no implants like that week. Or lack of the trained health providers are not trained in this like when they're in school. So they have to learn on the job, and then that's just kind of haphazard. And they're biased. This is one of the biggest things that our work is trying to influence. So then we essentially started with some qualitative work in Cameroon. And one of the biggest things that we found was that the providers really were reluctant to even talk about these methods because they didn't know how. They didn't trust themselves how to insert an IUD or an implant. They didn't know how to talk about side effects, which is not easy because you're talking about probability distributions. And then, they didn't know enough about their management and things like that. So the best thing is like, even when they administer these things, if people come back and complain about side effects, they say, oh, this didn't agree with you. And then they remove them quickly, right? There's no management of side effects and there's no follow-up, good follow-up, things like that. And then there's provider bias against recommending some of these methods, especially to adolescents and to nulliparous women. Right. So, and these urban myths still exist to this day, and they still exist even in the United States. Oh, if you haven't had a child and the IUD is not for you, etc. There are some legitimate points there, but they don't rise to the point of like not talking about them or not administering them at all. It's just, you just talk about them. But this bias, of course, matters a lot to people who don't know about their options. So if something never comes up, you cannot really ask for it. And then there's cost. So we essentially decided that we were going to develop an app, more like a job support tool for nurses who are doing the counseling, that was not only going to deal with a lot of these issues. And then, of course, we had to train the nurses in family planning in addition to using these tablet-based apps, but also it was going to be a data collection tool for us and deliver randomized interventions as well. So we hit almost like three things with one kind of thing. So we get a lot of very well-trained nurses. We have a tool that actually takes away some of their discretion on what to talk about because the app essentially guides the entire thing. Then the data gets uploaded into the cloud every day, so I get to see it. And then I can randomize things in there to say, okay, this client is actually going to get this kind of counseling and this client's going to get this kind of counseling. So that's kind of what I'm going to talk about today. So I'm going to skip the literature, but we're essentially addressing three bits of the literature. There's a big one on family planning services and quality of counseling. There's one with kind of like using apps and tools, mainly in the United States. There's these kind of like online apps or waiting room apps and things like that. And then there's a little literature that I'm not going to get into today. We had the experiment, but we abandoned it. Zero price versus very, very small epsilon price for health products. And, Jessica has done some work on this when it comes to, malaria, both the testing and drugs, and there's work on this on kind of like bed nets and things like that. But I'm not going to talk about that today, mainly because we didn't see much in our kind of like 0 versus 25 cents thing. And then we can discuss later on if you're interested why that might have been. So quickly, the setting. So this is in one hospital, and later on, if we discuss, so this is part of an adaptive experiment, but I'm only going to talk about the pilot phase where it was a static RCT, like the kind of RCT that you all know. Like it's in industry, they call them A/B tests, whatever. So people get assigned to just one thing or the other. And then throughout the study, that's what they have. And then at the end, you look at the results. But this is actually a part of then we are currently in the final phase of the adaptive experiment. And the reason we can do an adaptive experiment is because a healthcare setting is the perfect place to do an adaptive experiment where you have clients rolling in every day. So every day there's a new person to intervene with, so to speak. And then you can actually intervene with them, having learned from all the people that you've seen since you've started. So that's where the adaptation part comes in. And then that means that you can actually do this in just one place. Whereas in development economics, if you think about more common settings, let's say if you were doing interventions in schools, how you would be only able to do an adaptive experiment would be to split your sample in half or a thirds or something like that. Do it in one half first, learn there, and then go in the second half and then try the things that you've learned there, right? But with a hospital, I can actually, if I want to say, hey, I want to go on like 6 more months, I can just do that because I'm not running out of people, so to speak. The clientele may be changing depending on now there's a pandemic or something like that, but we can deal with those issues. So we're in one hospital. It's a women and children's hospital in Yaoundé. And what we've done is we've trained 9 nurses there from all the departments of this hospital. The reason for that is that when we arrived there were only 2 people who were doing family planning counseling, and they were actually in a department called family planning, right? This meant that the hospital was actually losing a lot of people who could have gotten counseled and wanted to adopt something because they were just in other departments and they didn't really think to ask. And it's not in anybody's checklist. And then even when those people ask, let's say by chance, like a maternity nurse says, hey, you just given birth, it's great timing for you to have the IUD, what do you think? She doesn't have any knowledge to do counseling herself. She has to go and get one of those FP people to come and give a counseling, but those people are busy, etc. So there's all these things. So we said, look, the easiest way to fix this leaky bucket problem is to just train everybody, because this is not easy, but it's not rocket science either. We can just do a good training. And then actually our colleagues, in the beginning, I didn't introduce you to all of my co-authors. One of them is a professor of OBGYN and head of research at the University of Yaoundé and at this hospital. So he essentially developed with his colleagues a training program for the nurses. And then they got trained for like 1 week. They practiced on clients with experienced colleagues and things like that. And then they got trained on the tablet apps to use them. And then now they all can do it. And then essentially now it's on their checklist that whenever somebody comes to vaccinate their child, or they've just given birth, or they come for an abortion, or they've had anything, or even antenatal, people get counseled when they're pregnant and they make a plan to adopt something after they give birth. They can now all do it. Our eligible sample is 15 to 49-year-old women who are approached and have agreed to receive a counseling session, and who said in their interview that they wanted to wait at least 12 months before they become pregnant again. This is the hospital in Yaoundé. It's a nice hospital. It's a bit more chaotic inside. It looks calm from the outside. But it's a specialized public women and children's hospital. So we developed this tablet-based app with a multidisciplinary working group comprised of nurses and doctors and public health specialists and behavioral economists and things like that. And essentially, it kind of mimics the best practices around the world for counseling, but it just essentially puts them in order so that if a nurse is actually following the protocols, it's almost impossible for them to skip an important step. Right. And what we do is that you can think of it as kind of like two parts. One is a needs assessment, and then there at the end of which there's a kind of a medical assessment to get at contraindications and things like that. And then after that, we get to a method choice section where our counseling interventions and our discount interventions are implemented. Right. And I'm going to show you now what I mean by those. So now what we did is that we, after heavy discussions with the nurses, like on kind of like what they do and how they would like this thing to work and etc. And maybe in the Q&A, we can talk about this more. The one thing that we realized very early on is that this job support tool really had to be a job support tool. If it was any burden at all to these nurses, this would have failed immediately. So it meant that the work that we put in to make this thing as useful to the nurses as possible along their desires on like, how should this work? Oh, this question is too long. It shouldn't be like that, etc. Blah, blah, blah. It was very important, the back and forth. And it took roughly a year to do that. Then in the end, what we did is that we said, look, now we want to learn whether the method we favor, right, actually works better than the method that you kind of used to do, but without the app. Of course, with the app, everything is much improved, but what we're trying to mimic is the involvement of the provider in making a recommendation or not, right? So in the status quo, I don't know how many of you are familiar with family planning counseling. In the status quo, generally the providers are asked not to interfere at all. The choice is completely up to the client, and you're not really supposed to opine that much. So we took that almost to an extreme, and essentially what we're trying to do is you go through the needs assessment, which is, like I said, already much improved because you go through all the things that you want to talk about, like a client's preferences about side effects, their fertility objectives, their experience with previous methods. whether they've been recently pregnant or given birth, all sorts of things. And then when you come to the method choice section, equipped with all of that information, there's now two ways we go about it. In one way, when we randomize people into this individual decision making, the nurse reads this text in black. And what it essentially says is that, look, there are a bunch of methods that we think will work well for you. Is it okay if I describe them quickly to you and then you make a decision, right? And what's happening is that the app has randomly given this order of these 4 modern methods that exist at this hospital: the IUD, the injectable, the pill, and the implant. And this order is randomized in this status quo regime, right? And what the nurse does is, like, she picks up these cue cards that we've adopted from Pathfinder. This is a cue card for an implant. This is the front of it, and this is the back of it, right? And then she picks them up. And then what we've done is, like, for this to go quickly, we've highlighted a few things on there, like few bullet points, like, you know, this goes in your arm, it's 99% effective, and, you know, it gives these side effects, and you should really be worried if you get this kind of a reaction, etc. So they do this about 90 seconds for each of these methods in the order prescribed by the tablet. So this takes about 5-6 minutes. And at the end of it, they say, okay, now that you heard about these methods that might be good for you, which one would you like to talk about in more detail? And the client, let's say the client says, oh, the IUD sounds good, let's talk about that. Now what they do is they pick up the cue card for the IUD and they go through it in great detail. Like, instead of the highlighted bits, now they hit like every note on there. And that can take anywhere from 10 to 15 minutes, depending on how many questions the client is asking, etc. But it can also be very short, because the client may realize that, oh, this actually is inserted inside me, like, that's disgusting, I want to stop immediately. So it can also end in like 2 minutes, but it can go 15-20 minutes. They go through this, and at the end of that, the provider says, well, now that you listen to this, what do you think? Would you like to adopt this, or do you want to hear about something else? If she says, I want to adopt it, we go to the next step. If she says, no, I would like to hear about something else, then the nurse says to her, well, out of these other 3 things that are left, which one would you like to hear about now? And then again, the key thing is, it's always the client choosing out of the available 4 modern methods which one she would like to talk about. And then she makes a decision. So that's the individual, what we call IDM, the individual decision making. The shared decision making, let me just go there. Actually, you guys are blocking my buttons. Okay, so let me go back. There we go. So now what happens is, here, again, the nurse reads the black text quickly and says, well, but this time there's actually a ranking, and the algorithm has ranked the methods from the best suited to this client based on what she told us already, all the way to the worst suited, and they come up sequentially. So in this case, it says the pill is the best for her. So essentially the nurse says, look, there are a bunch of things that might be good for you, but we think that pill is the best suited for your needs. Is it okay if we start our discussion by discussing that one? If the client says yes, they go ahead and they don't do that quick discussion. They go through the detailed discussion of the pill. And at the end, they ask her, do you want to adopt the pill or not? If she says yes, great. If she says no, then you see on the right-hand side now, we click the button, and then the next best suited method is the IUD. And we say, okay, the next one is IUD. Would you like to discuss that? If she says yes, we go through that until the client chooses a method. Okay. Now here, the key distinction is that we are essentially gently asking her, is it okay if we start with the method that we think is the best for you? And because we're being a little nudgy, we're giving her 3 chances, like at the beginning, at the front of the cue card, right? At the end of this front of the cue card, which are all the pros of the thing, right? We say, hey, do you still want to hear about this, or do you want to stop? she says, oh, I want to go ahead. And then we go to the back. And then we again, at the end, we say, what do you think? So she gets about 3 chances to get out of our recommendation. But if she doesn't, at the end, we say, okay, well, what do you want to do? I'm sorry, I should just go back. There we go. And then essentially, you know, we are making recommendations, but we're giving her a lot of choices to say, it's your decision. We're just telling you what we think is the best method, then the next best method, the next best method. So there's a recommendation there. And the ranking algorithm that the app uses isn't that complicated. We've devised it ourselves. And if you use our app, you can revise the algorithm as you wish by changing the underlying code. It essentially looks at how long the client said they want to wait, how strongly they feel about the side effects associated with each method, and then the typical use effectiveness of the methods. Right? So that's what we're ranking on. There's a third group that I want to quickly talk about, is that half the people who've come, they essentially say during the kind of needs assessment that they have a specific method in mind that they came to adopt. Like some of these people could be actually people who are there to renew their existing method already. Some of them has previous experience, but they had paused. And then some other ones, they don't have any experience, but their sister is super happy with the, you know, like the injectable, and they want the injectable, whatever, etc. So for them, the app directly goes to kind of to the end, kind of like we realized very quickly that forcing them to go through these things was like extremely painful, and it was very upsetting for them. They were just wanting to get in and out. Like they're like, look, I want the implant, just give me the implant and let me get out of here. So they essentially don't get randomized into anything. So the experiment on counseling is going to be here, whereas the experiment on prices is going to be among all 3 of these groups. And then we have a bunch of, so once they get through that and they choose a method, then there's a button that we actually let the client push, like we hand them the tablet and say, push here, and then she gets randomized discounts. And there's 5 of these discounts that they get. But for today, I'm just going to lump all of them together for the purposes of this talk. I'm going to show you discounted versus full price rates. But the thing to notice is that these prices are not cheap. They're about, like, the high price in this hospital is about $7 for a LARC and about $2 for a SARC. And we have quite heavy subsidies starting from 50% all the way down to 100%. And the prices for all methods are revealed at once. So, you know, the client chooses the method, and then the prices are revealed, and then they make the decision to adopt or not. And then we know all of these from the tablet because they get synced to the cloud. So our main outcome is going to be whether they adopted a LARC, a SARC, or nothing. And like I said, we have no attrition on this because, you know, every counseling session is recorded. So this is the full set of clients that got counseled and got through this. And not only that, but we also then have a separate audit firm that actually goes to the hospital once a month to just go through all of their records and essentially audits their receipts and things like that to make sure. And then we take a 5% sample of the clients to actually call them to say, hey, were you there on April 3? Did you adopt this method, so on and so forth. So we are pretty confident that the outcomes we see are the outcomes that eventuated. So now this is kind of like a flow chart of like how the things go. So we have 784 eligible clients in this pilot
Sorry, Berk,
phase.
can I stop you for just a second? And sorry, I'm off video.
Of course.
Grab
no problem.
my brown bag lunch. Can you just pause and say why you're focusing on LARCs as the outcome in particular for this?
Because they're so much more effective than SARCs.
But is that like, okay, I'm gonna save this to later then. Maybe you just.
Okay. Yeah, that's fine.
Yeah.
But you'll also see the results, and maybe that will resolve some of your concerns here. SARCs are extremely unpopular in this population.
Yeah,
So,
it seems like the way you set up the design is that you want to find the approach that gets women to their preferences, closest to their preferences.
correct.
Which
That's
is
correct.
not an approach that's designed to get them to LARC. Do you see what I'm saying?
Exactly, exactly. So actually, I'm glad you asked that, and let's talk about that here, because one of the things that gets really annoying when I present to economists is that they think that essentially we devised this rude thing that's just pushy, and regardless of what people say, it just guides them to larks. And that's not true at all. Like you'll see actually the realized rankings that we get. The realized rankings often, most often like come up with larks at the top, but not always. And it's actually, we do really take seriously what the client said. And then based on that, like it can be that the pill or the injectable, whatever was going to be on top. So it's not that this is a method that's designed to get people to take larks regardless of like what they were thinking. It's a method that's just kind of trying to balance client satisfaction and minimize discontinuations and switching later on, which are costly, but at the same time, do maximize. So you'll see the nudges. Actually, you asked the question again at the perfect place, because I'm going to quickly describe a nudge here about larks. But did that answer your question, or should we talk a little more about that?
I think so. I think it can also come up again, like how aligned these various objectives are. So there's like one objective is reaching her preferences, one objective is reducing discontinuation, and another objective is getting more people on larks. And I think they're not completely they're not completely the same. But I think I think we should come back to it. Yeah.
No, that's fine. They're not completely the same, although I'm pleased to tell you that they're quite aligned, at least in this study. So we like to think of them that way. Certainly, like for example, the discontinuations and things are very much like aligned for us because they're equally costly for the hospital to do. So we don't want them to, we don't want there to be a lot of women coming back and saying like, this thing is terrible for me, and then I don't want to use it, but I'm going to show evidence on that as well. So here, what's happening is that, so these clients come, and during the needs assessment, we figure out that 56% are actually saying, hey, I actually have a specific method in mind. And often that's a lark. Most often that's a lark. Sometimes people are wanting a SARP. You'll see actually out of those people, 80% it's a lark and 20% it's a SARP. For those people, if they say they want a specific method and that method is a lark, we say, okay, fine. And we don't really go through all the side effects and etc. We go directly to the final ranking where their method is at the top. And then if somehow they're contraindicated against that, or like they decide that they don't want it after all, there's a default ranking that comes afterwards, right? But if it's actually, they come and they say, hey, I really, really want the pill. We just gently ask, we say, look, it's great that you want the pill, but there may be other methods that might be equally suitable for you, if not better. Would you be open to discussing those other methods or not? And 2/3 of these people, we actually get them to say yes. And then essentially they go through down here, we ask them we elicit all their preferences, etc. Then they get randomized into one of our treatments. And then they actually do get to talk about other stuff because most likely a lark is gonna come on top. Whereas 1/3 of them, so about 6% of our total sample, say, no, I really do want the pill. And then they go to the end and then pill is at the top. This other 44% who weren't seeking a specific method, they just go through the normal stuff and then they get randomized. So that's how we end up with these three groups, okay? So now main results, don't worry, like you may be thinking, oh, he's doing terrible on time, but I essentially have one graph to show everything in just one graph, and you're going to see all the main results. So on the axes here, we have these people who had a method in mind, the short MIM for that, the status quo counseling regime where the client gets to choose which method they would like to discuss first and then afterwards, which we call IDM. And then the shared decision-making where the nurse actually opines a little bit based on the tablet's recommendations, right? On the y-axis is the percentage of people who adopted the LARC. Right? So let's start with the people who had a method in mind. If they got the full price, which like I said is about $6-7 in this hospital, 42% of them adopt the LARC, and then that goes up to 62% if they get a discount. And this discount is on average about, 50 to 75% on average. Some of them are zero, some of them are very little price, some of them are 50% price, etc. Right? Now, the interesting thing comes here. Now, people who had no idea what they wanted, and most of these people, I can tell you, have no experience whatsoever with a modern method from before, right? So they're really kind of like getting counseled for the first time. Only about 10% of them adopt the method in the status quo counseling regime if the price is full. That goes up to roughly 30%, so it almost triples if there's a discount on the price. So that's fine. But the interesting thing to note here is that comparing these two red bars, so this is conditioning on the price being full. If we counsel them with our shared decision-making approach where we recommend something, the impact also triples, right? Not only that, for that group in the STM, there is no price sensitivity whatsoever. So when we offer them discounts, the take-up doesn't go up. In the paper, we have a very simple model where the individual client is trying to maximize her utility, and she cares about two things: the price of the product and the perceived returns from the product. And essentially in the model, we showed that what must be happening is that the STM is increasing the perceived return so much that her willingness to pay goes above the highest price in our study. Therefore, offering discounts is completely pointless. And then they essentially get, they don't change their behavior because they're willing to pay the highest price anyway. Right? So that's the main results. So you can see, of course, that like to the extent that STM is cheap, it's way more cost effective because roughly you get this, let's say this 28%, this 35%, they're roughly the same. By the way, you have all these differences, and the difference in difference up here with the p-values, you can see that's actually this diff in diff is significant at the 10% level. So even if you think the discounted IDM and the full price STM did roughly the same in terms of take-up, you would likely prefer the STM because it's cheaper, right? I have to train everybody on family planning and using this tablet anyway. Doing the STM isn't really more expensive than doing the IDM. So I can save a lot of money by just not giving this discounts. Right? So now a few questions come up like that people ask us where they say, well, okay, you're just seeing this at the end of the counseling session. What about like actually maybe STM is causing a lot of people to adopt, but then they immediately discontinue, so your impacts would shrink. So these are the impacts over time, actually over a period of 180 days. And we can do this because we know from the tablets, essentially, when people return to do something. So we can essentially do a panel of like daily kind of like take-up rates. And what you'll see is that when the prices are full, this is the IDM, this is the STM, and this is the MIM, right? There's a little bit of increase. People just get them stuff more, but not the whole lot. But with the discounted LARCs, the impacts are actually increasing over time, right? So what happens is that not only STM is more effective, but it's actually more effective over time, because maybe some people were convinced that they want this thing that the nurse said is best for them, but then they didn't have the money at the time, and then they just wanted to go talk to their husband and etc. So over time, the impact slightly grows. It's not that much, but it's still a bit, right? And then you can see here, the take-up rates are also increasing. So now if I show you more granular, it will really show you. So these people at the top are green. They're the people who adopted a SARC. So this is the pill or the injectable. I call them short-acting methods. SARC is a silly name, but it works. You can see that people who adopted a SARC, they're pretty much all still using that SARC, Like this could be a little bit of an overestimate because they don't have to come back to the facility to discontinue. So, but we have follow-up questions as well, follow-up surveys as well, and we just don't see that much discontinuations and switching in the follow-up surveys. So we're pretty confident that this is a decent picture. So essentially, there's no switching for the people who adopted a SARC originally. For people who adopted a LARC originally, what's happening is that, yes, there is some removals. This little sliver green here is removals, but actually that is overtaken by the fact that a lot more people come and get a LARC when they didn't initially do so. So actually over time, the LARC uptake goes up because the net effect of people coming back and saying, hey, I had chosen the IUD, but I hadn't taken it because I didn't have money or I hadn't talked to my husband. That percentage is, let's say, 8-9%. And then the removals are 2-3%. So over time, we actually see an increase in uptake about 6 percentage points or something. And then this big green blob at the bottom is people who didn't adopt anything. And you can see in the beginning, right after the consultation, it's about 60%. It goes down to 50% after 6 months. That's one. The second thing is like people say, well, look, actually, maybe you were being kind of really pushy and this is not like a, consistent with the principles of counseling and for informed consent and things like that. What about that? One of the things that really surprised us is this graph. So what this graph shows is that how many methods did people discuss in detail? So I'm not talking about the highlighted bits, but going through the entire cue card for like 10, 15 minutes per method. Did people discuss with the nurse under each regime? So now this white one is the MIM people. Of course, they said, I came to get an implant. They discussed the implant and they took the implant or they didn't. That's fine. So they just discussed essentially one method and they left. The interesting thing is in the status quo, people are also like that. Even though they said, I want to discuss the pill, once they heard about the pill, if they wanted it or didn't want it, that was it. Most of them didn't go to a second method to discuss, right? When the nurse said, hey, do you want to discuss another method? No, essentially they ended there. Whereas in our STM, the shared decision making, less than 60% of the people discuss only one method, meaning more than 40% discussed in detail at least 2 methods, and 20% discuss at least 3 methods, right? And we have secondary analysis that suggests that the entire impact of STM is actually coming from those extra discussions, right? So part of this is generalizable in the sense that this is actually a kind of like a nice way of like getting people to say, hey, look, we think there are some, we're giving you some guidance, but we're still respecting your choice. And then you just tell us like, if you want to hear about the other methods that we think are good for you. But part of it is also a quirk of our algorithm, which in combination with being in Cameroon produces this result where our algorithm mostly puts the IUD at the top. And in Cameroon, implants are very popular. They have a familiar female name called Jadal. Everybody knows Jadal. So women somehow, like when they want a LARC, they mostly want an implant. So essentially what happens is a lot of times people will hear about the IUD, they'll politely listen, then they'll say no, and they'll then hear about the implant in the second or third place. So part of it is that quirk, but nonetheless, you would not have expected probably if I told you I have these 2 methods, which one do you think people discussed more methods in detail? You wouldn't probably expect to see this much of a gap. STM essentially produces kind of like almost more educational content about methods than the IDA. Right? And then the final thing is, let me show you the quick realized rankings of our app. So in position 1, you get 58% of the time you get the implant, 30% of the time the IUD, 30% the implant, and then it's about kind of pill. And then we actually consider lactational amenorrhea as well for people who are eligible. So it comes up a bunch of times in the maternity ward. So you can see that it's not like 100% we're pushing, But then it is actually a lot of times the larks are coming up on top. And the reason for that, again, is that we have a specific population who are walking into this nice hospital in Cameroon. And a lot of them are saying, I want to wait at least 3 years. And a decent chunk of them are saying, I'm done, actually. I have 4 kids, like I don't want any more children. So given what they're saying and given their side effects preferences, naturally larks are coming up on top, not because we're pushing them. So then the final thing I want to talk about, how am I doing on time? Oh, okay, perfect. I will just quickly show you heterogeneity results and we can have 15 minutes for Q&A. So what we did is we used some kind of machine learning techniques that my co-authors have developed. Essentially, you kind of estimate a conditional average treatment effect for each individual, and then you categorize them as the ones above the median and the ones below the median, right? So essentially, we are able to identify a group that's really strongly responsive to the discounts. Like this is not about the counseling, and then a group that actually not responsive at all. And the difference between them is actually quite significant. And the group characteristics are such that the group that's strongly responsive are younger. They're more likely to be university students. Because they're younger, they have less children. And they often want to space at least 3 years, if not longer, right? So essentially, there's a lot of kind of like, these are really motivated people to avoid pregnancies in the next few years. And for them, price seems to be a big determinant. So essentially, just simply using age or recent delivery status and things like that are easy things to target, which actually what we're doing in our adaptive experiment, if there's time to talk about that at the end. So then that's it. The one thing I guess I want to mention is that, so you notice here that we're in a population where they're walking into a hospital. And there was a part of this experiment where we were going to go to schools and youth centers and things like that, and then do a lot of promotion to get people walking through the doors so that they could get counseled, or we could counsel them where they are. But the pandemic thwarted all of those. So this is so far a kind of like, you can think of it as a, it's not a demand generation thing. It's among the people who are already there. But still, we consider this population to be a large population that's very low-hanging fruit. There were a lot of these women who were just walking out of these hospitals with no counseling and no methods. And what we've seen by simply instituting a checklist that say, hey, if somebody came to get the child vaccinations for their 4-month-old kid, just ask them, what their status is and if they want to be counseled. Not only are they receptive to counseling, they're receptive to adopting LARCs, and they're very responsive to both of our interventions. So at least there are a lot of women seeking healthcare for lots of different reasons. Just simply reaching them is low-hanging fruit, and it actually seems to be quite cost-effective. And if you're interested in the kind of like the ongoing adaptive experiment that we're doing, just feel free to ask me in the next 15 minutes, but also kind of email me, call me, tweet me, whatever, and then we can talk about it much more and I can share stuff with you guys. Thank you so much for listening. And there's amazingly only one interruption, which I'm not used to.
Anna, do you want to go first? Thanks, Berk.
Thank you for a very, very interesting presentation. I'm a reproductive health, maternal health, family planning kind of expert, definitely not an economist, and definitely not a technology person. And some of the things that you said made me, and I worked for the Pop Council for 12 years. So some of the things that you mentioned made me remember, Judith Bruce's and then Andrew Jane's quality of care, quality of family planning framework. And I don't know, when I hear these things, I get a little worried because did you make sure that there is no pressure from the provider in favor of LARCs? I mean, everything seems to be so objective based on the technology you are using. But we know that when LARCs are adopted at such high numbers, very often it is because there is some kind of pressure behind it. So that's one thing. Then you talked a little bit about discontinuation, and we know that with implants and IUDs, one important reason why continuation is high is because providers don't remove the devices, or women don't necessarily have access to a provider that would remove them, either because he or she is not well trained to do it, or because he tries to convince the woman to keep it, whatever. So basically, I'm a little worried about the ethical aspects of the work. And yeah, I wonder if you did any follow-up to assess women's satisfaction. Later on, I may have missed it because I was teaching during part of your presentation, but yeah, these are long and complicated questions. So whatever you can tell me, I would appreciate.
Yeah.
Thank you.
Jessica, shall I take this one by one? So can I answer this one
I
first?
think so.
Yeah.
Yep, go for it.
Yeah, okay. So yes, so exactly because we were worried about this issue, I mean, substantively, we were worried about it, not because you're going to ask about it, but because, we are worried about it. We actually have 2-week follow-ups that actually on average happen on 1 week after the counseling session. And we have a quality checklist that is validated by the PUP Council that we administer during that phone call. And we specifically ask about client satisfaction and whether they would return to this hospital and whether they would come to the hospital for FP services in particular or anything else. 2 things I can tell you. One is that the satisfaction rates are very high and the quality checklist is very high, but that's not surprising because the app is taking care of that. So, when you compare it, let's say, to some provider in India who is not trained and then they don't have a tablet, you can see that like they missed a whole bunch of things that they were supposed to hit because they just don't know, whereas the app here guarantees that. So I'm not surprised about the quality checklist being followed. That's like 92, 94%, but the satisfaction rates are around 90%, and they're not differential by the counseling regime, most importantly. So whether it's we're asking the client to say, hey, what method do you want to discuss versus we're revealing the rankings of the app, the satisfaction rates are identical. On your removals bit, I actually do think, so I was surprised because our removal rates are about 7% right now after 4 to 6 months. And, if you look at the Bible of like, the contraceptives, like in the US, like married couples, it's more like 20, 30, 40%, like after 1 year. I'd say essentially what's happening here is that this is a different population. This is a different population in their kind of like, a lot of them are much more likely to be single, they're not married. They've already said they want to wait like 3 years or never have a child again, etc. So they're very different than a typical married couple in the United States that's sampled for those. And because we were worried about removals, regardless of what intervention arm you're in, discount or no discount, IDM or SDM, all removals are free going all the way into the future, even if they come back 6 years later with their IUD. So we don't actually think that there's any reason for that. In fact, our sense from our qualitative work was that it wasn't so much a problem that the nurses are not willing to remove, they were too willing to remove. Like people would come back 1 week later saying, I have this side effect. And then they would say, oh, this didn't agree with you, we'll remove it, as opposed to say, that's actually normal. Let's wait for a few more weeks. Here is a medication that you can take in the meantime, whatever. So all of this to say, yes, I can't really convince you otherwise, but we've thought a lot about, the ethics of this. And actually our shared decision-making in the end is very much grounded in the recent literature on kind of shared decision-making and what role do providers have, etc. We as economists tend to think that it's a bit strange that in very busy kind of like clinics where there's a line out the door, you would just be having this counseling session where, people came to you for advice and then you just be saying, no, it's completely up to you and da-da-da. So we try to essentially streamline things a little bit without it being too pushy, but people will have their own preferences in the end of whether they want to use it or not.
Great,
Thank you.
You're welcome.
Leah,
Yeah, thank you so much.
introduce yourself quickly. You can,
Oh, okay, yeah. Hi, I'm Leah. I'm an MD PhD student. I'm doing my PhD in the Department of Global Health and Population. I think the project's really interesting. I really enjoyed the talk. I had a question about the women in the shared decision-making group, because you made this comment, if I understood correctly, that for a lot of women, they were getting recommended IUDs and then were opting to get implants instead. And that to me almost suggests that the algorithm is missing something about their preferences. And I'm wondering a little bit if you could speculate about what that thing is. Off the top of my head, it seemed like, one thing that you see a lot in the US is that women, particularly young women, opt not to get IUDs because they're worried about the pain associated with IUD placement itself, which did not seem to be a thing that was included in the algorithm. It seemed more like there were like longer term side effects that were included. Mm-hmm. And so I'm wondering, do you think pain could have been one of the things, or do you think there might be something else at play that was leading women to opt for the implants instead? Thank you.
Yeah, no, that's a good point. So there is work to be done there for sure. And it's in two aspects. One of it is there was a bunch of other things than the criteria that the algorithm uses that we could have put in there. But it would have just made the algorithm more complicated without necessarily being more effective, without trying. So for example, discretion is a big thing, right? And so we don't take discretion into account, for example, right? At least the algorithm doesn't. Like, so the nurses are trained. So if the client then when they're discussing says, oh, will my husband be able to feel the implant in my arm? The nurse will talk to her about that. That's part of it. But the algorithm doesn't say, oh, she said that she's really worried about her husband finding out. Let's not recommend her XYZ. It doesn't do that. So similarly, this thing that I talked about, this for whatever reason, people's preferences for Jadal are like much larger than the IUD. It's not there. But we do actually truly believe that given what people said to us about, especially the side effects that they'd like to avoid, when the IUD comes up on top, we actually think it's better for them, right? That's why it comes up on top. Now, there is at some point you got to give up, because if every single person that you say IUD for you and then they say no, maybe then your algorithm should save time and not waste 15 minutes of people's time to something they're going to say no to. But it's actually not true. We do have actually kind of like, I don't know, like 10, 15, 20% of people taking IUDs. And then, some of them probably wouldn't have if the implant came up first. I'm not sure. But if you're interested, there is work to be done here. We actually think that there's some machine learning to be done to learn kind of like what recommendation came up on top for what types of people. Did they say yes or no? Number, what recommendation did they eventually adopt? And then later on, did they discontinue or switch or whatever? And then go back and then actually improve the algorithm so that it makes better recommendations to save time and to save, So I think if anybody is interested in doing that, it's sitting there to be done for sure.
Great, thanks. So Maggie has a question in the chat, how providers felt about the tool and whether they wanted to keep using it. And then Seb just raised his hand too. So
yeah,
and I guess my question is also related to Jessica's point about how long it took. So anyways, just curious your thoughts on both those things.
How long it took? What?
How long the counseling took with this?
It was a question in the chat.
Oh, I see. I'm sorry. I ignored them because they distract me a lot. So
Yeah.
I'm relying on you to read them to me. So yeah, like I said, we developed these like with not only the head OBGYN, but also the head nurse at this hospital, like in a classroom first. But then when we were going back and forth with the nurses, like watching each, I've spent like countless days like in this room, like observing and etc. And then after each one, we do a debrief, etc. So their feedback actually made us change the app a lot. So now, like I can say in the Silicon Valley sense, like its usability is tested. Like this is an app that actually people like to use and it works. And they will definitely keep it. So the experiment is ending in 4 months. we are certain that they're going to keep using them because this is now the only way they know how to do counseling. And it's like, and they really enjoy it. And it actually raised the profile of the hospital because they think that the clients come and they see the technology, their view of kind of like the level of service that they're getting a hospital is also raised. And they enjoy like pushing the discount button and whatever, although when the experiment is over, that will also go away because they will set the winning price and then that'll be it. But definitely, I think the nurses like it, but I can tell you that they wouldn't have liked the version that I, with my colleagues in a classroom, came up with first. If we just tried to push that, that wouldn't have worked. But it's kind of like the whole back and forth for a year. It really did help. And you know, in the end, this is very interesting. Like when we first suggested it, just like the first question, like the nurses were shooting like darts at us, like with their eyes, like the stares that we were getting. They're like, what is it that you want to do? There's no way. But at the end of the 3-day workshop, they were saying, this is going to be so great for us because it's going to like help with, you know, we can't remember all the side effects and all the contraindications and etc. So those lists that come up in the method choice, they've already been culled for everything. So if you have hypertension, you know, the pill doesn't come up, right? So like, or if you've given birth recently, but it's been 48 hours, the IUD, you know, so there's all these things that they have to remember or consult a book for, etc. It's really helpful for them to be able to just kind of rely on the app. So they do like it.
Okay, I know we're at time, so if people need to drop off, they can. We'll take one last question from Seb and Berk. We're gonna copy the chat for you because there's a bunch of questions in there that hopefully will be useful for you. So Seb?
Yeah, thanks for
And
this.
I'm happy to stay on if people are wanting to ask questions past the time. That's okay.
That's very kind of you. And thanks for the presentation, Berk. I was curious to learn a bit more about the algorithm itself. Like, I guess I was wondering for the question that I put into the chat. Now, I understand the algorithm adapts according to how the interaction goes. Is that right?
No, so there's two, sorry. So the algorithm doesn't adapt. So the algorithm is fixed. So we've given a bunch of essentially scores to each of the client answers that we care about, that we think matter for whether a method is suitable for them or not. And then the algorithm just comes up with a ranking and it's in there. And in IDM, it's never revealed to anybody, not to the nurse or not to the client. And in STM, it's revealed sequentially one by one, right? The adaptive bit is the experiment itself, where what we're doing is we have an algorithm for assignment probabilities. So like, in the beginning of the experiment, everybody is equally likely to be in the IDM or the STM or in the discount or the full price. But then after we see 100 people next month, more people are in STM and more people are in discounts because we see that those things are working better than the status quo. So then, and then another month later, we further kind of like adapt. And then we do that actually contextually, meaning that we do that based on the client's characteristics, meaning that we're actually tailoring the best information or best intervention to each client. So adolescents get a different kind of probability distribution of assignments than adults. People who've recently given birth get a different probability distribution of interventions than people who haven't given birth, and so on and so forth.
Got it. So I guess what I'm curious about for both of those things, you know, for the shared decision-making part, you know, is there a lot of heterogeneity of sort of how this actually goes, or is there, you know, can you see empirically that this is all sort of very similar and therefore we can standardize it? And the same for the adaptive piece, you know, could you say that if a young person works in, let's say, an 18-year-old or something like this, we're 96% sure that this is the kind of treatment that they should get. And the reason why I'm asking is I'm sort of partly thinking about this all as from a sort of, you know, decision support tool, I guess. And you could imagine, you know, it's like it's being done, you know, you input certain things, you learn through the interaction, maybe or maybe not, you learn certain things about this person and sort of what might work best for them. And if there's no variability in that, then we can encode this very simply and train people according to it. And they don't need an app, right? They can just, they know, like the young person comes in, you start off with, you know, this method. the old person come in, you started with that method, and you're 95% sure that this is exactly what they want. So I'm partly sort of trying to, thinking about this, about decision support and what we can learn from your experiment on both of those, sort of the adaptive experiment piece, but also how the shared decision making goes. If you can extract any information on, whether decision support is useful in this setting, interactive decision support.
So Jessica, like I said, I'm happy to answer not only this, but more questions, but I don't know if you want to bring this to a formal close and then people can just stay in this room.
There are 2 o'clock classes, so I think we have to let students and faculty head over to those, but I think I have a few questions I wanted to ask you, so I'll send them to you by email, and we're going to copy the chat for you, and hopefully we can take it offline, as they say.
And feel free to ignore my question, Berk. That's fine too if you have to run.
No. But can I just answer Sebastian's question?
Sure,
or yeah,
sure.
Okay. So yes, I think you're right. So I'll start in the reverse order. So in the adaptive experiment, so essentially what we do is, like, based on the pilot data, we make a guess at kind of like what will work best for, let's say, people who are under the age of X, right? And then, like, we split that decision tree also by under the age of X and recently gave birth versus like not recently gave birth or something like that. We make a guess, and then we just kind of like learn from that, let the experiment run a bit, learn a bit more, adapt, learn a bit more, adapt. So often when it's like Facebook or Google doing this, and they have literally millions of clicks to deal with, those things converge very fast to something. And then they know, like, 98% chance that, like, this is it. And then that's what we're going to adopt, and then that's going to make us a lot of money, right? A blue commercial versus the yellow commercial or something for this type of person. In our case, our ability to do that is limited because we see about 10 clients a day. So and then we're splitting them into subgroups, and then we're splitting them into interventions. So in some of our regions, the algorithm actually didn't really converge to like a clear winner, right? So it's kind of like indicated something, but not necessarily. So currently that's what we're sorting out. Like we are evaluating the things that we think came closest to kind of being the winner, right? And then looking at those. With the algorithm, like I said to Leah, I think it's the same. We've just scratched the surface. There's a lot more to do there, kind of like using kind of like AI and machine learning techniques to say, look, there's actually the characteristics of all of these people who react differently to these kinds of things. So then it's not as simple as kind of like saying it's 18-year-old or not 18-year-old or something like that, for which you wouldn't need anything, but it's actually quite more complex. But then it's, again, I think there's 2 different kinds of things. Like for public policy, government will still want simplicity. So for a prices or for, like I don't know, like it's counseling methods or something like that, they want something not black boxy to be able to say, here is what we're doing. Like the prices are this for these people, then this for these people, etc. Whereas there may be other things where it's quite helpful to the nurse who's already using the app for the app to be actually quite sophisticated and tailoring things to the client that they don't really need to know about. They just know that it's actually doing a good job. And so I make a distinction between those 2 things. And in that latter, certainly we have a lot more work to do because we haven't even scratched the surface on those things.
Thanks, Berk.
All right, thank you for the
All right,
question.
Jade, I'm sorry to have to leave it there. There's lots of interesting comments and suggestions in the chat. This is
okay.
But thank you so much, Berk, for joining us. Sorry I couldn't be in person, and we really appreciate you coming. Hopefully we'll see you in person someday.
Yeah, next time. Thank you so much.
Thank you. Amanda, we can copy